disease.
Thank you, Chandrima, for giving me a chance for the IC, and thank you, AIOC, for giving me a chance for the platform. This is a real disease, the OCT interpretation. Okay. The rationale of the quantitative imaging in glaucoma diagnosis. The visual field, we all know that. But visual field has poor repeatability. As per the OAT study, it has been found that 86% of the abnormal and the reliable fields were not confirmed on retest. We need at least 3 consecutive fields to get a reliable field. But again, the controversy is there. If we go for the 2 consecutive tests of the abnormal and reliable test, it has found 66% are there. And when I go to 3 consecutive tests, it is down by the 12%. So number of tests, there is a discrepancy between the tests and their results. So structural loss precedes the functional loss, we all know that. Again, the OAT study, it has been found the optic disc assessment you may be missing up to 55% of the glaucoma patient. So this changes precedes visual field loss in most of the cases. So what next? The rational retinal nerve fiber loss precedes the visual field loss by the 6 years in 60% of the patients. These are some of the studies. In OAT study, HRT showed the glaucoma test changes 8 years before the visual field, 17% of the retinal nerve fiber loss before visual field detection. Progressive optic disc changes may not correspond to the RNF thickening in the same ways with glaucoma progression also. So what next? Next is OCT. We have the spectral domain OCT. In the OCT3, it produces 5 and 12 A scans with 1024 data points. And the resolution time is 8 to 10 micron. New machines can reach a resolution of 2 microns also. Image acquisition time is less than 1 second. Some of the older machines, the time domain is a sequential, is 1 pixel at a time. There's some fallacy at the very slow, where we can see the motion artifacts, and it gives a 5 and 12 A scans in 1.28 seconds. And now the newer one, the spectral domain, is a simultaneous one, 1024 pixel at a time, where you can see the small vessels also. This is the average retinal nerve fiber layer values at the 3.45 millimeter. Now the color coding. The thinnest 1% of the measurement falls in the red area. The thinnest 5% of the measurement falls in or below the yellow area. But the 90% of the measurements fall in the green area. And the thickest 5% measurement falls in the white area. So types of the retinal nerve fiber changes. It can be the widening of the retinal nerve fiber defects. It can be deepening of the retinal nerve fiber defect or development of a new retinal nerve fiber defect. Infrared temporal meridian is the most common in glaucoma. Compressive optic neuropathy has nasal and temporal defects and thinning. So rates of changes and age-related retinal nerve fiber loss, average rate is influenced by the greater the baseline thickness, faster rate of changes. No significant changes in the nasal and the temporal quadrant. Highest progression rate in 6 o'clock sector in the retinal nerve fiber layer. Perimetric glaucoma has higher rates than pre-perimetric glaucoma. Now we have gone for the retinal nerve fiber layer. Something new, the macular area. It is very important because in glaucoma, the macular ganglion cell mapping is important because very early cases, these are being damaged. In the RTV FD fluid domain OCT, the 26,000 scans per second is being done in the 5 micron axial resolution. And the ganglion cell complex is 7 millimeter scan area is being done, where you can see the ganglion cell complex clearly and visibly, and in the right hand side we can see the color coding of the macular thickness map. This is a glaucoma preferential thins the ganglion cells layer. It has been known and is proved. And the GCC complex includes the axon cells, bodies, and the dendrites of retinal ganglion cells. GCC measures the thickness of the 3 innermost retinal layers that are preferentially affected in glaucoma. It's 1 to 7 cells thick, less variable, contains 50% of the retinal ganglion cells. Average count is lower in eyes with early defects, but count can be affected by the drusen and AMD. GCC significance mapping. Again, the color coding mapping is there. Red shows the outside normal limits, green the baseline values within the normal limits, and yellow is the borderline. If we go for the deviation map, again the coding is there, color coding. Blue is the thinning of the 20 to 30% of the relative to normal, whereas the black is a more than 50% loss or greater. This is the one of the picture with the color coding. Even in the SD-OCT allows correlation of glaucoma disease pattern pre-perimetric glaucoma also. Measurement boundaries. Different machine gives different boundaries. In the retina, inner boundary is the interlimited membrane for all, but the outer boundary varies in all types of different machine, from status to top count to spectrals and other. In the disc changes, same happens. These are the 4 types of machine we are normally handling nowadays. The Zeiss is a time domain, one of the oldest one, and the Zeiss Cyrus, RTView, and the Heidelberg. Of these last three, you can find the Heidelberg spectrals give the 40,000 axial scans per second. It can find a very minute defect in the retinal nerve fiber layer. The database. The Stratus has a database of 28 subjects, and of this 63% patients are the Caucasian and only 11% are the Asians. In the Cyrus, 284 subjects, 43% are the Caucasian and 1% is the Indian as the database. Spectralis, 201 subjects, all Caucasians. This is the average retinal nerve fiber thickness measurement from Status, Spectralis, Cyrus, RTV, top count. All have the average between the 94% 4 micron to 100 microns, more or less equal. Retinal nerve fiber value OptiView. We can see the 4 quadrant from the same like the INC rule as that of the optic nerve disc. In the nasal part, you can see the 56% in the temporal, a little more. In the superior part, a little more thickness, and the inferior is the most thickness. This is the average studies of 2010. In the ganglion cell complex, the normal values are lower limit or normal values. Again, there is the average more or less. In the superior, if you go for the 76.69 and inferiorly 77.25. Again, the lower part is always the thickest part. In the glaucoma progression, rate of changes varies from patient to patient. The morphological changes commonly do not match neither chronologically or in the magnitude the functional changes. And the lack of accurate reference tests against which the accuracy of new testing strategies can be assessed. And this is an overview of a patient from 2009 to 2013. Slowly there's a change, the red flag is increasing. Is a new glaucoma module premium edition of the Spectralis 2, Heidelberg. It's a glaucoma progression analysis providing comparison of the normal aging slows the green line. This is normal aging. And the rim or any of the retinal parameters can be selected looking at it changes globally, always sector. Just change these parameters, just give a round of the ring. It will show the change whether it's deteriorating or coming towards the green line or not. These are the changes. Thank you very much.